All right, hello and welcome to today's webinar, Responding to Real-Time Health Data for Caret Home. I'm Katie Smith-Green and I lead our content here at Current Health. If you have any questions for our presenters today, please use the question function on your screen and we'll do our best to answer these at the end of the session. Today's speakers are Matt Wilkes, our Head of Clinical Research and Clinical Product Manager, and Tracey Baker, Director of Customer Success. Matt is a doctor with a background in anesthesia and critical care, specializing in remote medicine and human performance. He has practiced hospital medicine in the UK and New Zealand, as well as in more remote settings in India, Nepal, Bolivia, and East Africa. At Current Health, Matt focuses on surfacing meaningful insights from our platform to support our clients and partners and to grow the remote care evidence base. Tracey has more than 10 years in client operations, digital health, value-based care, and national quality improvement programs. At Current Health, Tracey is hyper-focused on delivering a best-in-class client and provider experience to improve healthcare. Before joining us, she led client teams at both Livongo and TimeDoc Health. With that, I'll turn it over to Tracey to introduce Current Health.
Thanks, Katie, and thanks, Matt, for advancing my slides. So welcome, everyone. I'm going to talk for a few minutes here about who we are, what we do, and what makes Current Health unique. So at Current Health, we enable our partners, that's health systems in the US, pharma companies, as well as health systems in the UK, to design, launch, and scale safe and effective care at home programs. We've been doing this for over 5 years now. Over 20,000 patients have been on our platform. And we started 5 years ago in the UK, assisting large health systems within the NHS. I mentioned that because it's super important for anyone on this call that's new to the Caret Home movement to understand that the UK has really been doing this for 20 plus years. And they have tons of published research that shows that the model of Caret Home is very safe, very effective, and really appreciated by patients and their caregivers. The acceptance rate in the UK is somewhere between 85 and 90%. Recent studies in the US have shown that patients in the US are open to it anywhere between 40 and 80%. But most importantly, Caret Home has proven results in improving patient outcomes. Specifically, we see lower 6-month mortality rates. We see lower 30-day readmissions. We see a decrease in falls at home. For our older adults, we see a decrease in incidence of delirium, less stress on the caregiver, and most importantly, the patient satisfaction scores are really through the roof. This is on a global level, and this is especially true with Current Health. We don't celebrate this enough, but our NPS score, is in the 80s, and our patient activation and adherence is always plus 90. That's important to really know in the area of remote patient monitoring, right? Because our NPS score is much higher than those other platforms that patients interact with within the healthcare space. And we know that patients, when they're sick and when they're not feeling well, the last thing they really want to do is engage more with their care. They really want something that's going to allow them to stay healthy, stay in place, and not interfere with their daily lives. Next slide, please. So what makes us a little bit different? So our platform allows, end-to-end support services for your Caret Home program. We really see in our customers that the biggest burden to implementing a Caret Home program is that last mile. So working through all the fragmented pieces of inventory and logistics, connectivity, in-home services, the command center that actually monitors the health data and health alarms that Matt is going to spend so much time talking about today. Supporting there for a 24/7 support, tech support line, and helping you develop clinical pathways, quality reporting, and we do all that with our dedicated ClinOps and customer success team to provide that sort of end-to-end support for your program. Next slide, please. Yes, so in case you haven't heard, we are joining Best Buy Health. So what does this really mean for our customers and patients? It really helps us solve two problems. Healthcare is and always will be, in our opinion, localized, and human to human. I have two favorite quotes from my friend Jason. He leads the Barrel Institute of Patient Experience, and his motto is to care is human. And, for my other favorite writer, Atul Gawande, he talks a lot about how healthcare is moving into the employer space, but so many of us only spend 2 years at a job. So in our lifetime, we truly believe at Current Health that patient care is going to be human to human, patient to doctor and nurse, and at a localized level. With 10,000 people a day turning 65 through the year 2030, we know that our partnership with Best Buy will allow and enable our doctors and nurses at a local level to deliver care at home with technology and that person-to-person experience. Next slide. All right, so I'm done sort of with my spiel about Current Health. I'm going to pass it over to Matt here in a second, but one more slide, Matt, if you can. So how is Caret Home evolving in the US? So across our client base, we are seeing customers implement Caret Home and use our technology across the acuity spectrum, whether that's in that high acuity hospital at home sort of use case, or just a non-continuous spot check of blood pressure for your hypertension patients. We support all of that. We support that entire spectrum, and Matt is really going to dive into how do we help you collect data, view data, monitor data, and act on that data that you're collecting from your patients. So Matt, I'll turn it over to you.
Thanks so much, Tracy. And it's a real privilege to talk to you all today. It's a really exciting time in remote monitoring. And I've been with Current Health about 18 months. Before that, I was working in critical care for COVID. And it's really nice to see this area of practice kind of exploding. And it's a pleasure to be able to share some of the lessons that I've picked up as a clinician within Current Health over the last 18 months or so. I found that it's one thing to believe in the healthcare technology and to be excited about the potential for remote monitoring. It's a whole other thing to try and do it. It's been a lot of fun, and I will try and share the lessons that I've learned, and I'd be very grateful in the questions in the chat to hear some of yours. So when we're thinking about how we're going to do remote monitoring, when we think about collecting patient data, the important thing is not to start with the technology. The technology is a tool. The thing to do is to think about, what are your goals? What are you trying to achieve? And within that, clearly, what patients are you trying to look after? And the way I like to think about it is, I think, right, well, I want to look after this group of patients. I want to, for example, keep them at home after being in hospital and try and avoid them being readmitted to the sort of bricks and mortar institution. So that then leads on to the obvious question, well, what are they at risk for? What is going to bounce them back? And having come up with a sort of a differential in the same way that you would as a doctor, what's common but not too worrying, what's rare but very worrying, what could happen to these people under my care? I then think, well, what are the signs that that's happening? What will let me know when something's going wrong? What will help me predict something that's about to go wrong? What will give me the confidence to say this patient can stay at home? And so I then choose the vital signs that I want to look for. I then, and only then do you actually arrive at the technology, think, how am I going to capture those vital signs? And then finally, once I've got them, what am I going to do about them? When am I going to worry? When am I going to be confident? And what that really then amounts to is, how can I be notified of change? And that's where alarms come into the whole thing. So these are the kind of the vital signs that you sort of end up tending to focus on. And these are kind of the same ones that you would see in a hospital observation chart. The kind of obvious measures of physiology: heart rate, respiratory rate, oxygen saturation. Skin temperature is an interesting one that we offer in our device. And I think it's something that has some positive predictive value for things like fever, but it also has some quite interesting things around shock and perfusion in general. So that's a one to watch. You can look at movement. Movement's actually particularly interesting because in hospital, when you want to know how a patient's doing, you go and look at them. And we're going to come back to the fact that you can't do that in the home. So any indication of how they're moving, how they're living, how they're going about their business is actually really useful in trying to contextualize what you see in the other vital signs. Then there's the other obvious ones that can be measured by peripherals like blood pressure or expiratory volume and spirometry. We look after a lot of COPD patients, so this is something that comes up a lot. So what to do with all of this data? we're living in this sort of age of massive amounts of data, and so triaging it becomes essential if you're going to provide effective care. And the easiest way to triage it is to set alarms. So when the data deviates from what you would like it to be, you, the clinician, are alerted. And so alarms are essential for knowing when to intervene, but they also, they one of the direct gatekeepers to patient outcomes, because if you know someone's sick, you can do something about it. The other thing about alarms, the dark side, is that they're the fastest way to annoy people. Like if they are constantly going off, then clinicians are going to lose trust and ultimately become complacent when actually a real health situation can be occurring. And you can't rely on the patients to know when a change becomes concerning. And in fact, it's unfair to, and it's your job as a provider to shoulder some of that burden for them and to take some of the worry away from caregivers onto your own shoulders. And so when I think about setting alarms, I need my alarms to be accurate. That goes without saying. I need them to be reliable. I need them to be explicable. Like I need to be able to say to a patient and another provider, this situation occurred, an alarm went off, and this is what follows. I like alarms to be auditable. I don't want just alarms to go off. I want to be able to go and look back at my patient cohort and see when they went off. Did they go at the right time? Were they sensitive? Were they specific? And any alarming system has to be scalable. And that's a technical challenge, but it's one not to be underestimated. So I mean, here are just a couple of examples that we've had from some of our providers. So we're involved, have been involved for a long time at Baptist Health in Western Kentucky. So this is a 65-year-old patient with advanced but not palliative chronic obstructive pulmonary disease who presented to the ED with an exacerbation, was treated with nebulizers and steroids, and was sent home with a current health kit. And according to her caregiver, she did fine during the rest of the day, but when the day wore into evening and overnight, her SATs dropped, her respiratory rate increased, and an alarm was triggered. Her care team responded and were able to bring the patient back into hospital for non-invasive ventilation. That's the kind of emergent side of remote care monitoring. And we've seen some lovely instances in the UK where alarms have alerted us to pulmonary emboli, to heart attacks, to a bunch of different pathologies. And we have some case studies on our website that kind of go into those in more detail. But the more typical one, and the one that actually I'm happiest about, is when an alarm enables patients to stay at home. That's where they want to be. That's where we want to keep them there, safe. And so this is a sort of typical thing of a 73-year-old with a urinary tract infection, again, given trimethoprim and sent home with a current health kit. When an alarm triggered for high pulse and high respiratory rate, she was assessed remotely. She was assessed by video call from our care team. And with the help of their son, we were able to work out via the camera that the patient had pitting edema in her leg, that she was fluid overloaded, that she'd been over-resuscitated when she came in dehydrated with her UTI. There was some suspicion at the time of deep vein thrombosis because she wasn't a terribly mobile lady and she had been dehydrated and she did have sepsis. But when they were able to rule that out with an in-home ultrasound, she could then be given a little bit of diuretic, rebalance her fluids, and she was able to stay at home. So that's the payoff, being able to keep patients at home. But having a patient in the home and having a patient in hospital when you're trying to monitor them is not the same thing. And it's a mistake to treat them in the same way. And the reason why you can't treat them in the same way when it comes to alarms is because when you look at a patient in the hospital and you say, I'm going to take your blood pressure now, or worse still, I'm going to count your respiratory rate. Anyone who's ever had their respiratory rate counted, immediately when someone says they're going to take your respiratory rate, you immediately start breathing very weirdly. So in the hospital, you say, I'm going to take your observations. Patient then sits awake, they're upright, they're aware of their breathing, and you take their observations from a specific site, say the finger in pulse oximetry. But more importantly, you can see them. So you can form your own judgment. You could use your own heuristics to work out whether you think this patient is sick or well. Now in the home, they're not sitting still. In the home, they're going about their activities of daily living. And those activities of daily living challenge patients' physiology in a way that being in a bed doesn't. And so you find stuff. You find undiagnosed conditions. Sometimes a patient wears the device inconsistently or incorrectly, and you have to work that out from afar. There can be mechanical interference. We once had a patient who had one of those gym vibrating machines. So they were kind of being moved around by this extrinsic source of vibration. And we were desperately thinking, do they have Parkinson's disease? What's happening here? You have to sort all these things out remotely. And there's always a time delay when a patient is being monitored remotely. That delay may be very short, but the results may be aggregated. They may be put together over 10, 15 minutes to give an overall average. And you have to take this into account when making your assessment. And I've got a really lovely example of this. This is a real example. So this is a patient, and along the x-axis is time, and these are in 12-hourly blocks. And on the y-axis is their oxygen saturation. And this would be your kind of typical hospital monitoring, twice daily observations. And you can see that their oxygen saturations are good. They're 98, 98, 99, 99, perfectly normal. Monitor them continuously, and you see this. You see a much bigger variation in their oxygen saturation. And that comes from physiological variability. That comes from the challenge of their activities of daily living. You also see this overnight drop that's repeated night after night. And this is a patient who had undiagnosed obstructive sleep apnea. So there is always a case for spot monitoring, and there's always a case for continuous monitoring. And it comes back to those questions I posed to you at the beginning. What are your program's goals? What's the population? And what's the risk? But you have to be aware that if you are monitoring a patient continuously, you're going to see stuff that you wouldn't necessarily see in a hospital context. And so your alarms have to be made meaningful within that framework. In a hospital, all we care about is that alarms are sensitive. When someone's physiology deviates, even for a fraction of a second, we want the alarm to go off, because you can walk to their bedside and look at them and see that they're okay. At home, we also need the alarms to be specific, because we have to make sure we're not sending an expensive ambulance to their door at 2 o'clock in the morning and waking them up. Because actually the whole point of them being at home is that we don't wake them up repeatedly. We don't expose them to the stresses of the hospital. That's what helps them avoid delirium. So we need alarms that are sensitive and specific, but we also need alarms that fit with our capacity to respond. If we're not able to send an ambulance around, if we're not able to contact the patient through video calling, then we have to have alarms that allow that within your clinical workflow. So how do we actually do this in practice? Well, what tends to happen is, as clinicians, we're comfortable with sensitive alarms because that's what we're used to in the hospital. So when we deploy with a client, what tends to happen is the alarms are initially optimized for sensitivity, because that gives people comfort and it helps them bridge that mindset of monitoring someone in a hospital to monitoring someone at home. Then inevitably, there are false positives, because if you have an alarm that is purely sensitive, it will go off at times when there's nothing wrong, when that physiological variability that happens at home, be it circadian or from activities, makes alarm go off. And that creates fatigue. Now, we in Caret Health try to stop it before it gets to that stage and guide people through this, but this is the kind of process that one goes through. Then you calibrate the alarms for specificity, and you end up at a stage where you're picking up the events that are meaningful. And in all our deployments, we've gone through this and we've never missed an event. Touch wood, I'm touching wood over here, long may that continue. So when we're tailoring these alarms, we're really very mindful of the use case as well, because if you're looking at patients over a long period of time, then your clinical goal is managing disease. So you give patients a low burden activity, just taking a daily weight or blood pressure, giving them a medication reminder, and you set alarms that are based on long-term percentage change. If you're looking at a patient in a high acuity setting, if you're trying to take them from the hospital and monitor them at home, avoiding readmission in that short term, then what you're going to do is you're going to give a more intensive monitoring pattern. You're going to use continuous data. You're going to take your daily weights and you're going to alarm on specific thresholds. So not long percentage changes, but when they've hit something like a high pulse rate, a high respiratory rate, a low oxygen saturation. So I've talked a lot about the general principles, but I think it's always really helpful to sort of finish on an example, something that says, okay, well, what do you actually do? So we have a whole bunch of different recommendations based on the population and based on the disease pattern that you're looking for. So these would be our examples of recommended alarms for that kind of UTI patient, that patient with minor infective pathology. Often in those patients, we don't actually send them home with a blood pressure cuff, but if we do, we look for both a high systolic and a high diastolic, or a low systolic and a low diastolic, again, balancing sensitivity and specificity. We look for hypoxia, tachycardia, respiratory rate, which we combine with SATs, because respiratory rate is often quite a fluctuant vital sign, and we need to add that extra element of specificity using oxygen saturation. But the bit that you'll notice is in all of these patients, in all of these readings, we do them over an hour. So this is not your hospital thing where as soon as the SATs deviate, the alarm goes off. We use time to ensure that these little activities that people do at home that derange their physiology are ironed out. We use time to add specificity to our alarms. But we recognize that everyone is different. So one of the things in our platform is that we enable people to change thresholds. If you have a patient who has a high respiratory rate normally, or who tends to sit with low SATs because they have COPD, we need to accommodate that. We need to recognize that not everybody is the same, because if not, you will have alarms that are insufficiently specific for that patient. So that's our kind of whistle-stop tour of how we set alarms in Caret Health, how we try and look at populations who would normally be in the hospital, who we want to look after at home, and how we make sure that we provide patient care that is sensitive, that is specific to their needs, and it is also within our overall clinical capacity to respond. Because if you can't respond, there's no point in monitoring them in the first place. So that's how we look at setting stuff. The thing is the tech is a portion of the battle. The clinical workflow is a portion of the battle. The real nuts and bolts of this, the real expertise is in how you manage that change and how you institute this intervention. And that's something that Tracey absolutely excels at in our organization. So to close this webinar, I'd like to hand over to Tracey to talk about some of the lessons she's learned in that implementation process.
Thanks, Matt. Yeah, so just going to spend the next few minutes kind of talking about the lessons learned that we have had with developing and eventually scaling monitoring and alarms for our customers. As Matt knows, I spent many years in my career working with surgeons and implementing surgical quality improvement programs. And my surgeon mentor, Cliff, he used to always tell me, Tracey, you know, people want actionable guidance and they can only remember 3 or 4 things. So give me 3 or 4 actionable things that I can do. So 2 quick stories. We had one customer that actually decided to start, putting together their alarms 2 weeks before go live, and then submit their recommendations by committee to like a private vote. So it was a very democratic process that ended up the first 9 patients, we over alarmed the staff monitoring them completely. In a second client, we had, very much focused. We were going with the current health recommendations based on experience from other customers. And then sort of a lead person in the risk management group at the hospital said, absolutely not. We're going to set the alarms as if we were treating this patient in the hospital. Resulted in over alarming. So bottom line, first step is start early. Start thinking about this as you're developing your patient populations, as you're deciding on the workflows, as you're determining your inclusion and exclusion criteria. Not only start early, but bring the right people to the table. Bring those folks in that you think may be naysayers, that may want you to really think about risk and how you're going to manage it. And absolutely bring those nurses and folks on your team that are going to monitor the alarms and be ultimately responsible for actioning the alarms. Number 2, do quantitative and qualitative research. So there's absolutely, guidance out there from the AHA, the ADA, about how to set alarm thresholds for spot monitoring of diabetes and hypertension. We feel very, closely aligned to that guidance. but also do qualitative research. So we often partner our clients with clients who have done this before to share their experience with alarms and how they started at a very conservative threshold and brought it down because they experienced over-alarming, overburdensome on the patient and the folks that were monitoring, as well as alarms that didn't actually result in any acute clinical situation. Remember your vision. So again, when you're doing Caret Home, when you're choosing a technology to enable you to do this, hopefully your vision is to provide better access to care, provide better outcomes, continue to deliver high quality care in the home that you would within the hospital without totally burning out your clinicians that are managing the program. And when you over alarm or when you set the alarms at a conservative level, you end up sort of negating that whole vision, right? And finally, what we help customers do is we help them with a decision-making tool. I have a decision-making tool that I love. It's called the soccer model, and we help them design, okay, these are our three options: status quo, doing alarms the way that we do them in an ICU or in a controlled setting, making them, over conservative based on that we've never done this before in our hospital, and this is what we feel most comfortable with, and the current health recommendations. We'll weigh those with the team, weighing pros, cons, and the ultimate trade-offs, providing a recommendation with both you and your team so that you can get the buy-in and support from those that are doing the monitoring, as well as those who are making the decisions to get your program off to a successful and scalable start. Katie, I think that's it.
Yes, we do have a couple of minutes for questions. Let's see if we can get through one or two of these. The first one is, do you have more guidance to provide about caring for specific patient populations at home?
We do. We look at this in two ways. We look at it in terms of what you're trying to achieve. So we have guidance for things like hospital at home or looking after patients in the post-acute space. And we also have condition-specific guidance for common conditions that we look at, like things like heart failure, COPD, sepsis, COVID, etc.
Wonderful. And another one was, how do your clients respond to alarms overnight?
There's two models, really. The first is that they do it in-house. Well, there's three models, actually. The first is that they do it in-house. The second is that they decide a priori that they're just going to look at alarms during the day, and they consent patients for that, and patients understand that they're going to do that. And the third model is that we provide our own clinical command center in which we have registered nurses who monitor the patients overnight, can escalate to a physician if necessary, and can get back in touch with the referring hospitals. That's something that we can take on as a company.
Thanks, Matt. It looks like that's all the time we have for questions today. Can you bring up our last slide, please? Perfect. In the next day or so, everybody will be sending you the slide deck and a recording of this session. You are absolutely welcome to share those if you find them helpful. Please take a moment as you exit to answer our brief survey. We really welcome your feedback for future webinars. And if you're curious about or planning a hospital at home program, we'd love to have you join us for a webinar in the next couple of weeks with our clients from UMass Memorial Health. They'll be sharing what they learned from setting up a hospital at home program in just a few months. That's it for us today. I hope you enjoyed this session. Thanks and have